Hello everyone and welcome to PW Medit. I'm Dr. Patil and we're continuing our Read Harrison series. Just give me a thumbs up if you are able to hear me loud and clear and if I appear live to you. So once you give me a thumbs up, we'll get going with today's topic that is about the systemic hypertension. So in the previous video module, I have addressed the pulmonary hypertension. Now today we're going to talk about more common topic which is systemic hypertension. I think most of us have encountered patients with systemic hypertension, or we have someone in the family or in a first degree relationship or in a close relationship we have someone with hypertension. It is so common and such an important disease for us to learn. Okay, so we'll begin first by defining blood pressure. We all know that when blood pressure is above certain predefined threshold, we will call it as hypertension. So first we should know what is blood pressure. So blood pressure is nothing but the pressure exerted by the column of blood laterally on the walls of blood pressure, on the walls of blood vessel. This is how we define the blood pressure. So basically when blood column moves forward, it exerts lateral pressure on the walls of the blood vessel. So this lateral pressure is what we call as blood pressure, and when it is above the defined threshold we will call it as hypertension. Now, what are the latest guidelines which are used for the diagnosis and management of systemic hypertension? Well, time and again, our guidelines get revised. So, from diagnostic cutoffs to the management targets, everything changes based on the recent literature, based on the evidences of treatment and its outcomes. So, that is why we should always be updated with respect to hypertension diagnosis and management guidelines. So among the latest guidelines, we have two important ones. One is International Society of Hypertension 2020. If you have been following me from last few years, then whatever I have spoken in YouTube videos in the past, they're all based on the ISH 2020. But since 2023, we have an update. So among the existing guidelines, the most latest is European Society of Hypertension 2023 guidelines. So whatever I'm going to talk today will be primarily based on the European Society of Hypertension 2023 guidelines, and these are the most latest guidelines. So we'll begin first by classifying the hypertension. As we know, systemic hypertension is classified into primary hypertension, which in our day-to-day conversation we also call it as essential hypertension, where you have hypertension, that is your blood pressure above the cutoff, and we do not have any identifiable cause. Now 90% of the patients we see today as having hypertension belong to this essential or primary category, but in around 10% of the patients we may have an identifiable cause. So whenever we have an identifiable cause, we call it as secondary hypertension. Okay, now obviously when I say secondary, there is an identifiable cause, and there comes the question, right? What are the common causes for secondary hypertension? So common causes for secondary hypertension that I want an undergraduate student to remember is, first thing that should come to your mind is kidneys. So we'll call them as renal diseases and renovascular hypertension and renal vascular diseases. So when I say renal vascular diseases, primarily I'm referring to renal artery stenosis. Renal artery stenosis. Apart from that, in the recent times, you have realized that plenty of patients are hypertensive because of the obstructive sleep apnea, and once we address their obstructive sleep apnea, the patients are coming out of the need for antihypertensive medications. So we will count that as a cause for secondary hypertension. And then apart from that, we have endocrine disorders. Endocrine causes for secondary hypertension. You can simply call it as endocrine hypertension. Within that, what all diseases I should mention? Azimuth, Nuceiba, Nature Lover, Oliveri Nucleus, Sutapa. Good evening, everyone. Good evening, everyone. Okay, so what endocrine disorders I should think of when hypertension comes to my mind? What endocrine disorders I should think of? Can I think of Cushing syndrome causing hypertension? Is it possible? If yes, what is the mechanism? Yes, Cushing syndrome can cause hypertension. Then you are very much familiar with the hypothyroidism causing hypertension, as well as hyperthyroidism causing hypertension, Okay, any other endocrine disorders? I will give you the clue. Patients present with episodes of palpitation. Whenever they come with palpitation, their heart rate will be high and their BP will be quite high. So what disorder I'm thinking about? Yes, the pheochromocytoma. Typically, we should think of pheochromocytoma in patients present with episodic hypertension. Episodic hypertension. Hypothyroidism usually causes diastolic hypertension, and hyperthyroidism usually causes systolic hypertension. So in hypothyroidism, there is stiffness of blood vessel that increases the diastolic BP, and in hyperthyroidism, generally there is increased cardiac output, or in other words, stroke volume, and your systolic BP depends or is directly proportionate to the stroke volume. So whenever we increase stroke volume, your systolic BP can increase. Okay, and even acromegaly and elevated aldosterone levels. So hyperaldosteronism. Hyperaldosteronism. These are all endocrine causes for hypertension. OSA stands for obstructive sleep apnea. Obstructive sleep apnea. Okay, so can anybody explain why Cushing syndrome is expected to cause hypertension? Cushing syndrome causing hypertension. Well, please remember, if you go back to your biochem or physio notes, you might notice that even the glucocorticoids have some action on the mineralocorticoid receptors. So they can stimulate mineralocorticoid receptors, increase sodium and water reabsorption, and thus cause hypertension. So these are all secondary causes for hypertension. Now, when it comes to primary, though we do not have an identifiable cause, obviously we can identify certain risk factors. So what are the important risk factors for someone to develop hypertension? If you ask me, sir, what is the single most important risk factor? I would say obesity. Obesity. Apart from that, family history. In terms of habits, smoking. Yes, alcohol is also a risk factor, but smoking is more stronger risk factor than alcohol. Family history, definitely yes. Around 1/3 of the patients with hypertension have a clearly traceable family member with hypertension. But if you ask me, sir, pick up one most important risk factor, I would say obesity. Is gender a risk factor? Yes. Unfortunately, males are at higher risk of developing hypertension than females. Gender is certainly a risk factor. So these are, in terms of diet, even diet is a risk factor. So in terms of diet, higher intake of sodium, though debatable with respect to recent studies, higher intake of sodium, lower intake of potassium, lower intake of fiber in diet, and higher intake of fat. These are all associated with increased risk of hypertension. Increased risk of hypertension. I forgot to mention, yeah, even lower intake of magnesium is associated with increased risk of developing hypertension. And whatever dietary surveys that we have done in the recent times, Indian diets are traditionally very much deficient in magnesium. And that is why you can see that in the social media, a lot of people are recommending magnesium supplementation. If you're obviously not getting or meeting the RDA of magnesium from your diet, even I would strongly vouch for magnesium supplementation. So these are the important risk factors. Now, among these, what are the modifiable risk factors and what are non-modifiable risk factors? So when we look at that, mostly it is the family history and gender, which are non-modifiable risk factors. Everything else is modifiable. You can lose weight, you can quit smoking, you can quit alcohol, you can modify your diet. Okay. So now that we are familiar with the risk factors, let us get to the main topic, which is the diagnosis of hypertension. That brings a very interesting point that happened in one of the offline classes. So one of the students was arguing with me saying that, sir, so even gender is a modifiable risk factor, even family history is a modifiable risk factor. So well, you can disown your family, but you obviously cannot disown the genetics that you have inherited. Similarly, you can go through surgeries, change your gender, but it is absolutely impossible to minimize the risk or make it zero because you're still carrying the same set of chromosomes. Okay. So, Samantha, pulmonary hypertension refers to elevation in blood pressure in the pulmonary artery and its branches. When we say systemic hypertension, we are referring to elevation in blood pressure in the aorta and its branches. The blood vessels giving the blood to the systems, right? Different organs and tissues, not the lungs. Okay. Now, what are the current diagnostic cutoffs for the diagnosis of hypertension according to European Society of Hypertension 2023? First thing we have to establish is what is the preferred method for recording BP. Now, I can record the BP in the hospital or clinic. I can record the patient in BP in the patient's home. Which one would you prefer? The BP recorded in the hospital or the BP recorded at patient's home? So you may be familiar with something called as white coat hypertension. So when we record BP inside the hospital or clinic, generally the BP tends to be higher than the patient's real life blood pressure. Significantly higher than patient's real life blood pressure. In fact, not just the patient's BP, even doctors and medical students' BP shoots up slightly the moment you step into the environment of a hospital or a medical college. Toxic places, right? Okay. So obviously that won't be the preferred method. What would be the alternate better? Recording the BP at home, which eliminates the possibility of white coat hypertension. Obviously, what would have happened in patient's last 30 minutes, 1 hour or 2 hours of life? He might have quarreled with the family members, right? Or he might have had an issue with the son or the wife. Those would influence the BP that we record at home. So that is also not the ultimate best. Yes, it is better than BP recorded at clinic or hospital, but not the ultimate best. So then what is the preferred method? Instead of recording at hospital or at patient's home, we can record the patient's BP 24/7. There are portable devices which patient can wear, and it will record the patient BP for 24 hours, and we can get the mean of it. That would be the preferred method, because even if there are some issues which are shooting up his blood pressure, the mean would still be closer to his real life BP. Right? So preferred method is 24-hour ambulatory BP measurement. Ambulatory BP measurement. Okay, Thakur Shaurya, I will connect with you. Though I am not an absolute expert on the NEET UG, I can help you connect with someone who can guide you. Okay, so Samantha, episodic hypertension basically refers to your BP being within the normal range but suddenly shooting up as episodes. During those episodes, BP shoots up and then comes down. This typically happens in patients with pheochromocytoma because these patients have tumors in adrenal medulla which produce catecholamine, dopamine, noradrenaline, adrenaline, and these are released in pulsatile fashion or in episodes. They're not continuously released. So whenever we release adrenaline, noradrenaline, dopamine, BP shoots up. After it is cleared from the body, BP gets back to the baseline or the normal value. Again, when the next episode of release happens, the BP shoots up. That is what we call as episodic hypertension. Okay, so we have established that ambulation means keep moving. So basically, patient wears a portable device which records BP continuously, and patient will be doing his day-to-day activity. So we will be recording his BP for 24 hours when he is carrying out with his day-to-day activity. He gets up in the morning, wears the device, does all his morning chores, does the routines, goes to the work or office, wherever he is working, comes back home, sleeps, and the next day morning he hands over the device, and then the device will tell us the BP readings, and we will take the mean BP of his 24 hours. This is the preferred method. What is the second preferred method when this is not possible? Then I would say recording the BP at home. Home BP would be the second preferred method. If that is not available, obviously something is better than nothing. I wouldn't say that don't record the BP if you cannot do a 24-hour recording or if you cannot do a home recording. In that case, we will record in the hospital, though we are aware that there is a possibility of white coat hypertension. Okay. Now this BP recorded at the hospital or clinic, in Western literature, it is usually called as office BP. That does not mean that we're sending some staff nurse to patient's office and record. For some reason, the Western world does not want to call hospital or clinic as hospital or clinic, rather they want to call it as office, and they don't want to call patients as patients, but rather they want to call them as clients. Well, that is more of a diplomatic terminology. For all practical purpose, office BP refers to BP recorded in the hospital or clinic. Now, when do I say that a particular person is hypertensive? When his BP is above cutoff. Now tell me, can I have the same cutoff if I record the BP at hospital or at home, or I do a 24-hour ambulatory measurement? Obviously no, right? I need to have a little higher diagnostic cutoff for office because I have to account for white coat hypertension, maybe slightly lower for home, maybe further lower for 24-hour ambulatory BP measurement. So let us look at how do we make a diagnosis of hypertension. So if you're recording the patient's BP in the hospital, if the systolic BP is more than or equal to 140, or if the diastolic BP is more than or equal to 90 millimeters of mercury, you can call it as hypertension. In between, I'm mentioning and or. What does that mean? It means any value above the cutoff is hypertension. It need not be both the values. Like if I give you a reading of, let me say, 150, 86, this is also hypertension. 150, 86, this will also be counted as hypertension because the systolic BP cutoff is 140 and it is definitely above the cutoff. Though diastolic is below the cutoff, we will still be counting it as hypertension. That is why I am writing here and or. Any one above the cutoff will be considered as hypertension. Now, if I'm recording the BP at home, then it is very easy to remember or recreate this table. Just go on deducting 5. So if your BP recorded at home is more than 135 or equal to 135 systolic and or more than or equal to 85 millimeters of mercury diastolic, we will call it as hypertension. But if you're doing 24-hour recording, please remember that in that 24 hours, even night is included, and in that night time, obviously BP would be significantly lower. So this mean will be lower. So the cutoff will be lower. Again, minus 5. So systolic mean more than or equal to 130 millimeters of mercury, or and diastolic mean more than or equal to 80 millimeters of mercury. We will call it as hypertension. Now, once we have diagnosed it as hypertension, yes, Kutapa, even any of the reading is above the cutoff, it will be considered as hypertension. Like if I have systolic BP, let me say 130 and diastolic BP 96. Diastolic is above the cutoff, it will be called as hypertension. We can use a separate terminology for it. You can call it as isolated diastolic hypertension or isolated systolic hypertension if only one value is above the cutoff, but it is still hypertension. Now, once we know the values for diagnosis of hypertension, we also have to grade the hypertension. So there is a grading that is followed in European Society of Hypertension 2023, where we have optimal BP, normal BP, high normal BP, grade 1, grade 2 and grade 3. Okay, so what is the optimal BP? The optimal recommended BP is less than 120 systolic and less than 80 diastolic. The normal will be counted as 120 to 129 and 80 to 84 millimeters of mercury. And 130 to 139, we will count it as high normal. And 85 to 89 diastolic also will be counted as high normal. Now, for grading, what readings we are using? Obviously, it is based on BP recorded in the hospital, that is office BP, based on office BP. So for initial diagnosis, you can follow the most preferred method, but once you made a diagnosis for grading, we will follow the office BP. So we all know, according to office BP, hypertension is when it is 140 systolic or above, 90 diastolic or above. So when it is that, right, 140 to 159 will fall under grade 1 and 90 to 99 will fall under grade 1 hypertension diastolic. For the grade 2, it is 160 to 179 and 100 to 109. And when your BP is more than or equal to 180 systolic and or your BP more than or equal to 110 diastolic, we will call it as grade 3. Now I will give you a value. You should tell me what grade of hypertension you would think of. Office BP. BP is systolic is, let me say, 160 and diastolic is 114. So what grade of hypertension it is? Look into the table and give me the answer. What grade of hypertension it is? 160, 114. And don't miss out on the middle column and or. So again, I'm reiterating, any value, be it systolic or diastolic, any one of them also, if it is outside the threshold or appropriately falling into a category, we will be categorizing it as belonging to that grade. For example, here you may think that okay, 160 belongs to grade 2, but when I look at the diastolic BP is more than 110. So this patient will be assigned the higher grade, which is grade 3. So this will be counted as grade 3 hypertension. So now we know how to make a diagnosis and how to grade it. Now, before I go to the management, if I don't treat a patient with hypertension, what is a big deal? Because most of the patients say same thing, right? Sir, I am fine. I am not having any trouble. You recorded the BP and you are telling it is high. I don't have any symptoms. So why do you want to give me medications? Obviously, to convince patients. So that's what I'm emphasizing. I put a small column in between saying and or. So obviously we have to choose the highest grade that we can assign to the patient based on their systolic or diastolic BP. From systolic BP 160, yes, we can think that it is grade 2, but diastolic BP is more than 110, right? So when it is more than or equal to 110, highest possible grade is grade 3 for this value. So we will be assigning it as grade 3. So we all know that hypertension is a silent killer, and untreated hypertension can lead to a lot of consequences. So we should be aware of the consequences. We should convince our patient that these are the consequences, and that is when they will be agreeing to start the medications. Now, what consequences I can expect? The consequences can be classified as acute and chronic. Now, what acute problems I can expect when I have hypertension? Mainly three organs bear the brunt of sudden rise in blood pressure. The first one I would think of is brain. When brain gets affected because of sudden rise in BP, we can call it as hypertensive encephalopathy. See, between systolic and diastolic, whichever fits into the highest possible category or the highest possible grade, we should be assigning that grade. Okay. Hypertensive encephalopathy is one acute emergency. Then we know that patients of hypertension at increased risk of stroke. And when I say stroke, it includes both ischemic stroke as well as hemorrhagic stroke. Ischemic as well as hemorrhagic stroke. Then apart from stroke, these patients can develop acute kidney failure, AKI. These patients can develop acute heart failure. Acute heart failure. The mechanisms behind this we will discuss in individual videos when we take up stroke, acute kidney injury, and acute heart failures. For now, just be aware that your brain can suffer the consequences, your heart can suffer the consequences, and even your kidneys can suffer the consequences if the BP suddenly shoots up. Similarly, long-standing elevation in BP is associated with increased death risk or mortality because of various complications. So within that, I would say the patients can, because of long-standing hypertension, can develop the chronic kidney disease. As we know, hypertension is the second most common cause for CKD. What is the most common cause for CKD? Obviously, diabetic nephropathy, right? So when hypertension starts affecting kidney, we can call it as hypertensive nephropathy. Then apart from that, hypertension increases the risk of chronic heart failure. Hypertension increases the risk of retinal involvements. We call it as hypertensive retinopathy. So plenty of consequences are possible. And can I say that if you are having hypertension, your risk of death is significantly increased in comparison to someone who is not hypertensive? Yes. So studies have shown that when BP increases beyond the normal range, every 10 millimeters mercury increase in BP for a prolonged period is associated with 30 to 40% rise in the mortality risk. So obviously, to reduce the risk of death and all these organ failures or consequences, I need to consider reducing the BP or treating. So now we know why we need to treat. The question is, how do we treat? So according to ESH 2023 guidelines, we have three categories of patients in whom we would be considering treatment of hypertension. First one, obviously all these numbers are based on office BP. Based on office BP. Okay. So the first one is when your BP is more than 150 systolic, more than 150 or more than or equal to 150 systolic, or more than or equal to 95 diastolic. We need to immediately start the pharmacotherapy. So these patients need to start on medications, start pharmacotherapy. What drugs to start, I will discuss later. Wazir, I missed left ventricular hypertrophy. Again, a very important point indeed. What you say, long-standing hypertension leads to increase in the afterload or the resistance created by the aorta and its branches. So to push blood into blood vessels which are offering resistance, left ventricle needs to do a lot of work. When muscles do overwork, they develop hypertrophy. So left ventricle can develop hypertrophy. And the problem doesn't get solved there because left ventricular hypertrophy does contribute to development risk of developing the heart failure. At the same time, when you have higher muscle mass, it needs more blood supply, and if you're not able to give it, it also can increase the risk of developing ischemic heart disease, because as the muscle mass increases, its need for blood supply increases. If you're not able to match it, we can develop ischemic heart disease or even M. Okay. Now, for patients who are having BP more than or equal to 90, but no HMOD. Now, you may be asking me, what is HMOD? HMOD refers to hypertension mediated organ damage. So, whatever we discussed here, these are all hypertension mediated organ damage. So, if you are having BP more than 140/90, but there is no evidence of hypertension mediated organ damage, we have checked your creatinine, we have checked your retina, and we have done the basic screen, and we don't find any hypertension mediated organ damage, and patient does not have high cardiovascular risk. Now, do you think I should start the medication straight away for these patients or try some lifestyle modification first? Obviously, see, BP is reasonably fair. There is no evidence of any hypertension mediated organ damage going on, and cardiovascular risk is low. So for such patients, we will think of first step would be to go ahead with the lifestyle therapy or lifestyle modification. How long I can wait after I've instituted the lifestyle modification? What lifestyle modification we'll discuss later. But once I've instituted, like basically speaking, some exercise, some dietary modification, salt restriction, how long I should wait to see whether the BP is controlled or not? Well, it is for 3 months. Now, after 3 months, there are two possible outcomes. If the BP is controlled, then I will continue with lifestyle modification as long as BP is controlled. Continue lifestyle therapy as long as BP is controlled. But if BP is not controlled, obviously I cannot rely on just lifestyle modification. If BP is not controlled, I have to initiate the medications. BP not controlled, we have to start the pharmacotherapy. Clear? Now, there is one extra point which is emphasized in the European Society of Hypertension 2023 guidelines, that is, if patient has already a coronary vascular disease, like he has chronic stable angina or he has suffered through MI in the recent past, right? If he has coronary vascular disease, in such cases, it is worthwhile starting medications even if the BP is more than or equal to 130/80. So if it is with coronary vascular disease, we have to start pharmacotherapy. We have to start pharmacotherapy. Clear? So 3 categories. First thing is anyone with BP more than or equal to 150 systolic or more than or equal to 95 diastolic, we are starting the drugs. If patient is having even BP of 130/80 but he has a coronary vascular disease, we are starting the drugs. Any other patient who does not belong to these categories, we would probably consider lifestyle modification, provided they don't have hypertension mediated organ damage and coronary vascular disease risk. We will see for 3 months. If BP is controlled with lifestyle modification, we will stick to lifestyle modification as long as BP remains controlled. If not controlled, again we have to start the pharmacotherapy. So I will give you a scenario. Tell me what you want to do here. You are familiar with the approach, right? So in this question, we have a 45-year-old who is diagnosed with hypertension based on his office BP of 148/92. 148/92, right? In such situation, should I directly start the medication? We would directly start medication if it is 150/95 or if 130/80 with coronary vascular disease. So in the history, nothing of that sort as having chronic stable angina, IHD or heart failure is mentioned. So obviously this patient does not require direct initiation of pharmacotherapy. And the treating doctor aptly has put him on lifestyle measures and followed up after 3 months when his BP was recorded as 138/86. What is the next step in management, 148.92 to 138.86. So what do you want to do? You would continue lifestyle modification or start pharmacotherapy? So let me see your opinions on this. Would you continue lifestyle modifications or you would start him on medication? You are familiar with his starting BP, right? So let me wait for your response before we take the discussion forward. I just want to understand your thought process. At the same time, I have a key message to deliver based on what answer you give. What do you think should be doing? 45-year-old, 148.92, initial office BP 140/90 plus is hypertension, so he is hypertensive. It is not more than 150 or 95, and there is no coronary vascular disease, so obviously lifestyle modification will be the first step. Step done, 3 months followed up, we know the BP. What should be the next step? So futuristic search says we should start pharmacotherapy. But why? The BP has dropped significantly, right? 148 to 138, 92 to 86. Well, there is an important point to learn here. If I just flip the scenario and say that there was a patient whose blood glucose levels were 400, and I started him on some lifestyle therapy. Obviously, I wouldn't do that. It is not appropriate. But after that, his blood glucose level becomes 200. What do you think? Should I continue with the lifestyle modification or start medications? In this case, most of you are going to say start medications because you would say, sir, sugar is not controlled yet. Well, true, right? So why we need to have a control? Obviously, if I do not control, then I will have the risk of all these organ damages, right? Now, to be able to minimize the risk of organ damages, I need to take the BP to less than 130/80. As long as it is more than 130/80, you might have brought it down from 200 to 150 or 200 to 140. Great drop, but still patient runs the risk of developing all these organ complications. So that is why we need to have a target, because beyond this target, above this, even if there is a significant decrease, there is still risk of consequences. So to minimize the consequences, I have to keep below this. So for that, like if I'm giving you the example of sugars, then we primarily use HbA1c as a marker for glycemic control. HbA1c less than 7 minimizes the risk of organ damage significantly. Similarly, when it comes to hypertension, the recommended target is less than 130/80 millimeters of mercury, but not less than 120/70 millimeters of mercury. Means you should not go below this, but you need to maintain below 130/80. In other words, I would say 121 to 129 systolic BP and 71 to 79 diastolic BP. That is your safe zone, right? When you maintain BP in this range, the risk of organ injuries, whatever we are talking about, left ventricular hypertrophy, CKD, retinopathy, nephropathy, they get significantly minimized. So the target is defined, set for most individuals. In elderly, we can have little relaxed cutoffs, but for most individuals, this would be the reasonable target. Now, how do I achieve this target? Once I've diagnosed a patient as hypertension, the target is set. I need to take his BP to less than 130/80. How do I reach there? First is obviously lifestyle modification. What comes under lifestyle modification? First one is the salt restriction. How much salt restriction I would recommend? So please remember, patients are expected to take less than 2 grams of sodium per day. Sodium per day. That roughly equals to less than 5 grams of salt per day. So salt and sodium, as you know, are not same. Right? So less than 2 grams of sodium or less than 5 grams of salt per day. Apart from that, there is need for dietary modification. What is recommended with respect to dietary modification? We need to have a diet high in potassium and fiber. Obviously, when I say diet high in fiber, primarily I'm referring to whole grains, not the polished grains, and I'm referring to green leafy vegetables and fruits. And then diet low in sodium, which we already know, and also diet high in magnesium. Today, magnesium is an important factor for the development of hypertension because the amount of magnesium in our diet is steadily declining. Okay. Apart from this, even lifestyle therapy also includes exercise and obviously quitting all the habits that patient has got. So what exercise I would recommend? We would recommend them to do primarily aerobic exercises, for 150 minutes per week. So that roughly transforms to 30 minutes of aerobic exercise per day, 5 days a week and 2 days of rest. Okay. And obviously patient should make an attempt to quit smoking and alcohol. And I would strongly vouch for significant weight loss if patient is overweight or obese. I personally would vouch for this because it makes a lot of difference to BP control and diabetes control. Once you lose weight, it becomes much more easier to control your blood pressure and diabetes with minimal or sometimes even no medications. So these are the lifestyle modification that you would institute. If patients specifically ask for, sir, recommend a diet, because obviously you say high in potassium, low in sodium, high in magnesium, they may not understand. If they specifically ask you, sir, recommend a diet, what diets we can recommend? The diets which have been studied clinically to say that these dietary approaches make significant improvement in BP. Those include two of them which are well studied. The first one is the Mediterranean diet. If you Google or search on YouTube, you will get plenty of Mediterranean diet recipes. Basically, this is a diet which is loaded with green leaves and vegetables and whole grains. And the second one is a specifically designed diet called as dietary approaches to stop hypertension. Dash diet or Mediterranean diet can be recommended. Okay. Now going back, Avinash. Avinash, okay, good. I'll come to that. I'll come to that. I'll come to that. So now we know when to start treatment, right? Anyone with systolic 150 or more or diastolic 95 or more, we're directly starting medications. Anyone with a coronary vascular disease with systolic 130 or more or diastolic 80 or more, we're directly starting medications. For everyone else, we are probably starting with lifestyle modifications, hoping to get the BP to less than 130, 80, not reached. For such patients are also, we're starting the pharmacotherapy. Now we know what comes under lifestyle modification. We will take a quick look at how pharmacotherapy is instituted. Now, if given a choice, would you like to treat with a single medication or multiple medications? What would be your preferred choice? Welcome future medicos and welcome Avinash. If given a choice, you have a patient whom you have diagnosed as hypertension. Either you started with lifestyle modification or direct pharmacotherapy based on his BP readings and other factors. Now we have come to initiation of drugs. What drugs would you start? Single or multiple? Which one would you prefer? Starting with only one drug or a combination therapy? Obviously, yes, future search are absolutely right. So today we prefer to follow polypharmacy or combination therapy rather than monotherapy. The simple reason for that is to reach a target of 130, 80, whatever is the starting point. If I have to rely on single medication, probably I need to use higher doses of those medications. And when I go higher with the doses, I obviously run the risk of developing side effects of those medications. Instead, if I add another drug, I can use lower doses of both medications to achieve the same target with minimal side effects. That is why we prefer combination therapy. Now, according to ESH guidelines, what is the first line treatment? First line treatment is a combination. See, there are some categories of medication which are considered as first line agents. What are those? AC inhibitors, ARBs. Okay, let me tell you what is considered as frontline medications. Primarily a pharma question. Frontline meds. There are 4 classes. The first one is AC inhibitors. Second one is ARBs. Third one is calcium channel blockers. And the fourth one is diuretics, primarily thiazides or thiazide-like diuretics. Thiazide-like diuretics. These are considered as the first line medications. We have to make a choice out of these. Obviously, we are creating combinations. As I've already told you, currently we prefer combination therapy. So what will be the first step? Among these, which one is directly hitting the underlying pathophysiology? Generally, in essential or primary hypertension, where we do not have an identifiable cause, it has been observed that there is upregulation of RAS activity. that is renin, angiotensin, aldosterone axis activities increased. So obviously I would try to counter that as the first step. So we will start with either an AC inhibitor or a ARB, both ultimately act through the same mechanism. Plus, to minimize, I don't want to use the very high dose of these. I will keep the dose low. So to minimize the side effects, I will add a second drug which will help me achieve the target. What I can add as a second drug? Either I can add a dihydropyridine calcium channel blocker, CCB, or thiazide or thiazide like diuretic. I can make a choice between these two. This is fixed. I have to either use AC inhibitor or ARB plus one of these. Plus one of these. Now, if I'm not able to reach the target of 130/80, again, follow-up happens at intervals of 3 months. So at the end of 3 months of starting these medications, appropriately titrating the dose, if I'm not able to control the BP, so then what will be my next step? Around 60% of patients, or I would say two-thirds of the patients, will be well controlled with this approach. If not controlled, I will add the next step. So what do we do in next step? I will continue with these medications, right? So in the second step, we continue first line meds, whatever we had started. And if the BP is not controlled, what else I can do now? If it is not controlled, I will come to beta blockers. Yeah. So you have choice of adding beta blockers. Beta blockers are preferred in certain settings. See, as a first line step, you would have started with these two medications or these two. Like you would have started with AC inhibitor or ARB plus a thiazide like diuretic, or you would have started with AC inhibitor and the dihydropyridine calcium channel blocker combination. Whichever you have not used from the frontline medication, use it. Whichever you have not used. So if I had started with, let me say, AC inhibitor plus dihydropyridine calcium channel blocker, I would have added thiazide like diuretic. And if I had started with thiazide like diuretic, I would have added calcium channel blocker. So continue first line medications plus add unused drug from first line. That is, either you would have used dihydropyridine calcium channel blockers, or you would have used thiazide or thiazide like diuretic. Whichever you have not used, choose one of them. Now another 30% of the patients will be well controlled with this. Now once you reach this stage, now I'm using 3 drugs, right? Either AC inhibitor or ARB plus dihydropyridine calcium channel blocker plus thiazide like diuretic. So we can also call it as triple therapy. So this you can say it as dual therapy because we are using 2 drugs. Now here I will call it as triple therapy because by this time we have a combination of patient is on AC inhibitor or ARB plus dihydropyridine calcium channel blocker plus he is also on a thiazide or a thiazide like diuretic. So we are now using 3 drugs and patient's BP is still not controlled. In such cases, we call the situation as resistant hypertension. If I'm not able to control the BP to less than 130/80, despite use of 3 drugs out of which there is a diuretic involved, we will call it as resistant hypertension. So in such situation, what is the only pending thing that I have not addressed from the RAS? See, from the RAS, I have blocked the angiotensin, either directly blocking the receptors with ARBs or reducing the production of angiotensin 2 with the help of AC inhibitors. Unexplored part is aldosterone. So I can try to block that. So in third step, we will add. Again, I'm mentioning add. That means we'll continue with the first line medications, whatever we had started. Whatever we had reached the second step, the 3 drugs will continue, but we will add spironolactone. Spironolactone. In fact, there was a question in one of the exams asking what is the drug of choice for resistant hypertension. The drug of choice for resistant hypertension, as Wazir and Avinash mentioned, will be spironolactone, right? This is going to be our approach. Let me take the question. Patient is having palpitations, ECG normal, BP 150/90, not revealed with ACE inhibitors. Avinash, you mean not controlled with ACE inhibitors alone? Well, if you are going by the ESH guidelines, I wouldn't say that you should be starting the ACE inhibitors alone. You should have added a dihydropyridine calcium channel blocker or a diuretic. If not added, you can consider adding either a diuretic or dihydropyridine calcium channel blockers. Personally, I would prefer adding the calcium channel blockers over the over the diuretics. Diuretics I would generally bring in the second step. Okay. Now, few points about resistant hypertension. What is resistant hypertension? Resistant hypertension refers to BP not controlled to target. Controlled to target. In the current context, the target is 130/80, less than 130/80, despite use of three drugs. Despite use of three drugs at full or optimally tolerated dose, out of which one is a diuretic. At least one is a diuretic. So if you are following the ESH guidelines, at the end of step 2, we would have reached a stage where we can call it as resistant hypertension. Now, what can cause resistant hypertension? Resistant hypertension can be because of pseudo resistance, and in our practical experience, pseudo resistance is the most common cause. Now, what do I mean by pseudo resistance? There is no true resistance. Primarily, we are encountering the situation where three drugs are not able to control BP simply because patient is not compliant with your medications. आपको लगता है कि आपने 3 ड्रग दे दिया है, लेकिन पेशेंट शायद एक ले रहा है या कुछ भी नहीं ले रहा है या प्रॉपरली कंसिस्टेंटली नहीं ले रहा है. So poor compliance to medications or other substances or drugs interfering with medications, interfering with antihypertensives. Like for example, if patient is taking cocaine, right, no matter what antihypertensives you give, his BP is not going to come under control because cocaine will cause potent vasoconstriction. His BP is bound to be high. Okay, so step number 1, when we have resistant hypertension, try to rule out pseudo resistance. Take a good history, understand whether patient is consistent with medications or not. Once you ruled out pseudo resistance, then start thinking about true resistance. So when we have true resistance, what other causes I can think of? Renal and renovascular causes, which is nothing but your kidney diseases. You know that when you study about glomerulonephritis, you mentioned that there is hypertension possibility. In CKD, you mentioned that patient can develop hypertension. And renal artery stenosis, obviously patient will develop hypertension. Now to rule these out, what minimal investigations I would require? To rule these out, what minimal... Avinash, see, there are 2 categories of the calcium channel blockers, as you know, the dihydropyridine and non-dihydropyridine calcium channel blockers. The non-dihydropyridine calcium channel blockers do have an activity on the AV node. They inhibit the AV node, and obviously that is the reason why we use them as antiarrhythmics. And I do not want to fiddle with my AV node in a simple hypertensive patient, so I wouldn't be using them. So I would prefer the dihydropyridine calcium channel blockers. Among them, the most tested is the amlodipine. Yes, amlodipine. There is a variant of amlodipine called S-amlodipine is what is most commonly followed by many of us today, because it has reduced risk of causing pedal edema, which is a bothersome symptom for patients with amlodipine, and similarly cilnidipine, which has reduced risk of causing pedal edema. So nowadays we prefer using either S-amlodipine or cilnidipine. Obviously, you can achieve the same BP control that you can achieve with the amlodipine when you appropriately titrate the dose. Okay, so now tell me what minimum investigations I need to do for the renal and renovascular hypertension. So I would require renal function tests, right? Then I would require at least a renal artery Doppler, renal function test and renal artery Doppler, and then endocrine hypertension. So obviously, what minimum investigations I would require? The investigations I would require to rule out the endocrine causes for hypertension would include 8 AM cortisol, or if not 8 a.m. cortisol, you can do a midnight salivary cortisol, which is now one of the standard screening tests for hypercortisolism. Then you can do the TSH to diagnose thyroid disorders, and you can also use insulin like growth factor 1 as the screening test for acromegaly if you're suspecting, if there are clinical pointers towards it. And you can also do for pheochromocytoma the serum or urine metanephrines for recognition of pheochromocytoma. Now, when you rule out the common causes for resistant hypertension, you don't find anything like compliance is fine, renal functions are fine, endocrine causes are ruled out, then we call it as true resistant hypertension. So there are two terms here: pseudo resistance, resistant hypertension, and true resistant hypertension. Resistant hypertension is where your BP is not controlled despite use of 3 medications in which one diuretic is involved. Pseudo resistance is where this is all happening. Your 3 drugs are not able to control because patient is having either poor compliance or is taking other substances or drugs which are interfering with your medications. Or it can happen when you have kidney disease or endocrine problems, or it can happen when you don't have any of this. So when you don't have any of this, still your BP is not controlled with 3 drugs at full dose, including a diuretic, then we use the term true resistant hypertension. And if they ask you what is the drug of choice for resistant hypertension, obviously it is going to be spironolactone. So that's it for today about the basics of hypertension. In the next session, we will discuss the hypertensive urgency, emergency, and malignant hypertension and how do we manage them. From this, a lot of MCQs are asked. So please spend some time on the app solving the MCQs. I will also bring some MCQs in the next class on this topic. We will solve them and then begin with the acute issues with hypertension. So with that, I'm signing off for today. I'll see you in the next class. Till then, have a good time. Avinash, right? 24-hour, obviously 24-hour urine or serum metanephrines. Both can be done. Okay. See you in the next class, guys. Till then.